In Unit 2, we will discuss the individual blood components and how they're prepared. This is Part 1. The goals of blood collection is to maintain the viability and function of the different elements that we collect in a unit of blood. We also want to prevent physical changes, and this will involve additive solutions. This may involve different types of storage temperatures, and then minimize bacterial contamination, especially for those components that are stored at room temperature. Anticoagulant preservative solutions are key to maintaining the viability of our blood components. Anticoagulants will prevent the blood from clotting. This is the same concept that we use in phlebotomy, where we have the different additives in different tubes, and their purpose is to prevent clotting of the blood. Preservatives provide nutrients for the cells. Once we collect the blood in a bag, it's no longer being fed by the human body. So we artificially provide nutrients to extend the life of the cells after collection. Heparin is an anticoagulant that's rarely, if ever, used anymore. It is an anticoagulant only. It's not a preservative solution. This component must be transfused within 48 hours, preferably within 8 hours. So moving along, heparin was one of the first anticoagulants that was used to preserve blood. Next came citrate phosphate dextrose, and there's two formulations. And we started with CPD first, and then they went on and added adenine for CPDA1, which effectively extended the shelf life for the red cells. So the storage time for CPD is 21 days, and for CPDA1 is 35 days. Both of these blood components are stored at 1 to 6 degrees centigrade, which is refrigerator temperature. What is the purpose of putting it in the refrigerator? Is to slow the glycolytic activity. Glycolysis is the process by which cells use glucose for energy. So if we slow down the metabolism of the cells, we can extend their shelf life. Adenine, there's none in CPD, and in CPDA1, its purpose is a substrate for ATP synthesis. The volume for both is 450 cc's plus or minus 10%. The dextrose supports ATP generation by the glycolytic pathway, and citrate prevents coagulation by binding calcium. You must memorize this chart, each component of this chart. The next generation of anticoagulant additive solutions came about with a substance called additive solution. It's abbreviated AS. There's a primary bag that contains the blood with satellite bags attached, and one of the satellite bags has the additive solution. The unit is drawn into citrate phosphate dextrose, which has a 21-day shelf life. So how do we get the Adsol into our blood bag? First, the whole unit of blood is put in a centrifuge, and they do a soft spin, and this is to separate the red cells from the platelet-rich plasma, PRP. The PRP must be removed within 72 hours of collection. Once the platelet-rich plasma is removed, then the satellite bag is opened to dump the Adsol solution into the red cells. Adsol consists of saline, adenine, glucose, and mannitol. This extends the storage of red cells to 42 days. And just a historical note, when this first came out, it had a 49-day shelf life. But we were noticing that towards the end of that shelf life, there was a lot of hemolysis. So the manufacturer was mandated to cut off a week for the storage time. The final hematocrit is approximately 66%, because remember, we've removed not all the plasma, but we leave about 20 cc's on. So again, the final hematocrit of this type of product is 66%. We're going to talk about the changes which occur during storage, and the first component of this is shelf life. Shelf life is also known as expiration date. So when you buy milk at the grocery store, you always want to get the one with the longest shelf life, because when milk goes bad, milk goes bad. So it's the same concept when we're looking at components. At the end of expiration, the unit must have 75% recovery of the product. What does that mean? For red cells, at least 75% of transfused cells remain in circulation 24 hours after transfusion. Well, how did they figure this out? Well, they're scientists, and what they would do would be to tag the donor red cells with some type of tag, transfuse it into a patient, and then calculate by drawing their blood 24 hours later how many of the tagged red cells were still in circulation. One important concept in transfusion medicine is the effect that the storage lesion has on blood products. The storage lesion is biochemical changes which occur when red cells are stored at 1 to 6 degrees centigrade. This affects the oxygen dissociation curve. Now think back to hematology, bring that back to the front of your brain. The oxygen dissociation curve causes an increased affinity of hemoglobin for oxygen, and that's not a good thing. So as 2,3-DPG levels decrease in stored blood, the hemoglobin has an increased affinity for oxygen, means it binds more tightly. So less oxygen is then able to be released to the tissues. The change in pH in the unit of blood drops, which causes the 2,3-DPG levels to fall. The good news is, once transfused, these red cells will regenerate ATP and 2,3-DPG. There's few functional platelets present, which is why we never give a red cell component, a packed red cell component for platelets. Viable or living RBCs decrease. The two patient populations for which the storage lesion must be kept in mind is for infants and massive transfusions. Infants have a very small blood volume, and having low 2,3-DPG levels and the affinity of oxygen for the red cells could be very deleterious to them. And in massive transfusion, you're just dumping stored blood products into them. So this could definitely affect the ability for the oxygen to be released to the tissues. So the summary of biochemical changes involved with the storage lesion are as follows. The pH will decrease, 2,3-DPG levels decrease, ATP decreases, potassium comes out of the cell and will increase in the plasma, the sodium decreases, and plasma hemoglobin increases. Why does the plasma hemoglobin increase? Because as cells die, they fall apart and release the hemoglobin from the cell. You must memorize these changes. I found this picture which kind of nicely illustrates the lesion of storage. So on the left-hand side, you see the red cell and the sodium's going into the red cell. The potassium is coming out. And then it shows you the different changes, the plasma hemoglobin, the potassium, and so on. Now let's get into the actual preparation of components. You want to collect the unit within 15 minutes to prevent activation of the coagulation system, because we're going to use the plasma components to make coagulation factors or products for the use to prevent coagulation. It's drawn into a closed system. It's a primary bag with satellite bags with a hermetic seal between. If the hermetic seal is broken and the blood is exposed to the air, this unit must be transfused within 24 hours if it's stored at 1 to 4 degrees, or 4 hours if it's stored at 20 to 24 degrees, which is room temperature. So here's the entire process. The whole blood unit is centrifuged with a light spin, and the platelets are suspended and this is called platelet-rich plasma. So light spin, remove all of the platelet-rich plasma except for maybe 20 to 40 cc's. Then the plasma must be frozen solid within 8 hours. And they have a special machine to do this. It's really cool that they plop all the plasma units in there, and within minutes the plasma components are frozen. Once you have the plasma frozen, we can make another product by thawing the plasma at 1 to 4 degrees. You put it in the refrigerator, and an insoluble precipitate will form as this thawing process occurs at 1 to 4 degrees. This plasma is then centrifuged, and you express all the plasma leaving the cryoprecipitate, which is about 15 to 30 cc's. It's not very much. Once the cryoprecipitate is separated, it is stored at minus 18 degrees. That's in the freezer. The red cells, if you have a CPD unit, it's good for 21 days. If you have an ADSOL unit, it's good for 42 days. And these are stored at 1 to 6 degrees. So I want you to memorize the process for how the components, the order in which the components are made, and the temperatures that they must be kept at. I love this diagram. I know it's too big for a slide, but it really nicely illustrates the process and how components are made from a unit of whole blood. So you'll want to spend a little bit of time with this. It has arrows that direct how the process is moving and a description of each step. So in summary, 1 unit of whole blood can produce packed red cells, fresh frozen plasma, cryoprecipitate, single donor plasma cryo-removed, and platelets. And this allows us to treat patients for the component they need. If you are very severely anemic, you don't need plasma, you need red cells. So by giving whole blood to a patient who is severely anemic, we can cause some devastating effects to that patient. We have a device in the blood bank that really makes it easy for us to prepare components. This can be used in the donor center as well as the transfusion service. And this machine is called a sterile docking device. And what it does is you have tubing on one side that goes to a satellite bag, and then the tubing from the donor unit. And what this does is you close it up. I've used this many times, and it will seal the two tubings together without ever exposing them to air. So this is just a wonderful device. It's really saved a lot of product, because once you enter a unit, if it's stored at 1 to 6 degrees, it's only good for 8 hours. So this is also used to pool components, which we'll talk about those components later on. In the donor center, quality control of components must be done, and this requires a certain number of blood products to be tested at regular intervals. So we have to sacrifice approximately 4 units per month of whatever blood product. So if it's cryoprecipitate, we need to make sure it has this much factor VIII. If it's red cells, we need to make sure that the hematocrit is this much. We must ensure product preparation results in a component that meets the regulatory agency's guidelines for number or quantity of the component that's in the bag. So as I said before, blood is separated into components to specifically treat patients with the product that they need. The advantages of component separation is it allows the optimum survival of each component. For example, if we left the plasma on the red cells, the coagulation factors will decrease rapidly. But if we go ahead and separate and freeze, then we can preserve those coagulation factors. And this allows us to transfuse only the component needed. Like I said, if you have somebody who's going into DIC, they need cryoprecipitate as one of the components to help stop the process. Transfusion practice, transfusion of any blood component requires a doctor's prescription. all components must be administered through a filter because there's particulates that we don't want to go into the patient. You want to infuse it quickly and definitely within 4 hours. What we tell the nurses is to transfuse as fast as the patient can tolerate it. So if you have an older person, you may want to take the whole 4 hours. Whereas you have a young person, usually they can do very well with a rapid infusion of the blood. D is an antigen that is present or absent on cells, and if you do not have the D antigen, we need to give you blood that is negative for that antigen. It is one of the most immunogenic antigens, meaning if a patient who is D negative is exposed to the D antigen, they have a very high chance of creating an antibody. ABO identical is preferred, but ABO compatible is okay. So you will learn during your blood typing lab that, for example, Group O is the universal donor for red cells because it doesn't have any A antigens or B antigens. It's a naked cell. And for plasma, AB is the universal donor because the AB person will not have anti-A or anti-B, which would attack those types of cells. Fresh whole blood is a very rare animal because the blood is not usually available until 12 to 24 hours after it's collected and processed. We have to get all that serological testing done. It has to be screened for the presence of bacteria. And so, again, we used to be able to get very fresh blood, not anymore. People or patients who are candidates for fresh whole blood are newborns who need an exchange transfusion. And what we do is we mandate we have to use a unit that is less than 7 days old. And we try and get it as fresh as possible. 3 days is wonderful because in an exchange transfusion, we're removing baby blood and then we're putting in donor blood. And it's a slow process, but eventually the baby's blood volume is replaced with donor blood, and we want it to live the longest life that it can. Patients requiring leukoreduced products. It's not a problem here in the U.S. because the products are leukoreduced immediately after collection. So once they collect the donor units, they take them to the back and immediately hook them up to a leukoreduction filter and filter them. So remember at the very first I told you about chunking information. And for blood components, if it's liquid red cells, it's stored at 1 to 6 degrees. If it's platelets or cryothawed or granulocytes, it's stored at 20 to 24 degrees, which is room temperature. Any frozen plasma product must be stored at less than or equal to minus 18 degrees centigrade. Any liquid plasma product except cryo is stored at 1 to 6 degrees. Liquid cryo is stored at room temperature. In the following discussion, we will focus on the most commonly used blood products. There are some very unique blood products that can be made, but we're going to talk about the ones that are most frequently used in the transfusion service for patients. Components may be altered in many different ways, which changes the name and in some cases the expiration of the blood component. So let's talk about the different types of blood components, and here again we're going to go ahead and chunk the material. So for cellular, we have red cell products, platelets, and granulocytes. For plasma products, the most common ones that are made are FFP, fresh frozen plasma, and cryoprecipitate. We're first going to discuss those products with red cells. Whole blood is just as it came out of the body. It's everything. Nothing has been separated. The clinical indications, as we discussed before, for the use of whole blood are extremely limited. It's used for massive transfusion to correct acute hypovolemia, such as in trauma and shock and exchange transfusion. It's rarely used today, even for a massive transfusion. The platelets become non-functional. The labile coag factors are gone. So it's best just to treat the patient with those components that they need. Even for babies, when we do exchange transfusions, we'll use red cells and fresh frozen plasma because those together have the blood components that are needed for the infant. This product must be ABO identical. What that means is if you are a Group A person, for whole blood, you have to get Group A. If you are an AB person, you must get AB. And that's because the plasma contains ABO antibodies that in a sufficient amount will coat and then cause destruction of a patient's cells. For example, we know Group O is the universal donor for red cells. If you transfuse a person with Group O whole blood, especially 2 to 4 units, this could create hemolysis in the patient. So when we're preparing blood components, the first thing we start with is a unit of whole blood. And there are time limits for component preparation because the longer the component is stored without separation and proper storage, there are changes. Again, the labile coag factors are gone. The platelets are dead. So the day of blood collection, within 8 hours, or if you store it at room temperature after 24 hours, you want to go ahead and separate the whole blood into its components. After storage at 4 degrees for 24 to 72 hours, you can make the red cells, but the platelets and the FFP cannot be made. Now, you can still salvage the plasma because that can be used for certain types of patients. But so far as getting a fresh frozen plasma, no. Red blood cells are also known as packed red blood cells or PRBCs, and this is used to treat symptomatic anemia and routine blood loss during surgery. So a patient comes in, for example, sickle cell patients are the best choice, which you don't have much of in Montana, but throughout the country, it's not uncommon. And they are good. If they have a hemoglobin of 6 to 7, they're good. And we're not going to transfuse them. Now, in a healthy person, if you come in with a 6 to 7 gram hemoglobin, you're going to need a transfusion. And then the doctor does a calculation to determine how much blood you need. But again, you don't need plasma products. You're not bleeding out. You just need the red cells. So why give you anything but red cells? The hematocrit for a packed RBC is about 80% for non-additive CPD and 60% for Adsol additive. The Adsol, I can't recall how many cc's, but it's quite a large volume that's added to the blood. And again, this extends the shelf life of that unit of blood. So how do you make RBCs? You can either allow them to sediment out on their own or, much faster, centrifuge the whole blood, then express the supernatant plasma out. Leukocyte-reduced red cells. This is done because leukocytes can induce adverse effects during transfusion, primarily febrile, non-hemolytic reactions. Unfortunately, a febrile non-hemolytic transfusion reaction is usually due to white cells, but can be the first sign of a hemolytic transfusion reaction, where the donor cells are being rapidly destroyed by patient antibodies. Reactions to cytokines produced by the leukocytes in transfused units are thought to be the culprit in causing this type of reaction. Other explanations to the reactions include immunization of recipients to transfuse HLA or granulocyte antigens, microaggregates, and fragmentation of granulocytes, which if they're fragmented, they release their contents, which is something the patient may react to. Historically, this was indicated only for patients who had 2 or more febrile transfusion reactions. Now, it's a commonly ordered popular component. In fact, as I said before, all blood in the United States is leukoreduced right after blood collection, because the longer you wait, the white cells start dying and releasing their contents. So we want to remove as many intact granulocytes or white cells as possible. Leukocyte-reduced blood is also called CMV safe. cytomegalovirus safe since CMV lives in the white cells. And by removing the white cells, then you dramatically decrease the risk of transfusion-transmitted CMV. Again, most blood centers now leukoreduce their blood immediately after collection. And if not, if you have non-leukoreduced blood, they have special filters that instead of a regular blood filter, the nurse will hook this unit of blood up to a leukoreduction filter, which will remove other particulates as well as the white cells. And again, since going universal leukoreduction, we have seen a dramatic decrease in the febrile non-hemolytic transfusion reactions. So this is an illustration of what occurs at the blood donor center. We have the blood bags that are immediately hooked up to a leukoreduction filter, and then there's a satellite bag here at the bottom to where the leukocyte-reduced blood goes. Washed red blood cells is another type of product, and there's a unique population that needs this type of blood. Washing will remove the plasma proteins, the platelets, the white cells, and microaggregates which may cause febrile or urticarial reactions. Patients requiring this product are most commonly the IgA deficient patient with anti-IgA antibodies. And we're going to bring immunology back to the front of your brain, but remember there's 5 antibody classes, and IgA is the one that is found in your fluids. And unfortunately, there are people in this world that don't make IgA. And when they're exposed to IgA, they look at that as an antigen, and they make antibodies to it. And all normal people have IgA. So when a patient is identified as IgA deficient, and this is usually through electrophoresis, then you have to give them washed cells. And we have a machine that is like a washing machine, and I've operated this. We would wash blood on a regular basis because we had special patients. But it washes the cells 3 times with saline to remove the plasma proteins as well as the white cells. And there's a donut, and the blood goes into the donut, and saline is added, and it just like a washing machine. And then it centrifuges, and then it removes the supernatant, and it has a red cell detector because you don't want your red cells going into the wash solution. There's 2 types of labels: washed red cells, which do not need to be quality controlled for white blood cells, meaning we don't do a white blood cell count on them. Or if you're washing the blood to create a leukocyte poor product, then you have to perform QC. And in order to be called a leukocyte-reduced washed RBC, you have to have removal of 85% of the white cells. This is no longer considered an effective method for leukoreduction, but before the advent of leukocyte filters, we had no choice. This unit expires within 24 hours after it's entered because you've broken the hermetic seal. So this is a picture of a cell washer. On the left-hand side, you have the unit of blood. On the right-hand side, you have saline. And you just turn it on, hook it up and turn it on, and it will automatically wash 3 times. Frozen blood is a very unique component. Frozen red cells, and once they're thawed out, they're called deglycerolized red cells, serve a unique purpose in transfusion medicine. Blood is usually frozen to preserve rare types or for autologous transfusion or stockpiling blood for military mobilization and or civilian natural disasters. What happens is blood is drawn the same way as any other unit of blood, and the plasma is removed and glycerol is added. Glycerol is a cryoprotective agent, so it goes into the cells and it then prevents them from forming ice crystals when it goes in the freezer. After equilibration of the donor unit, once it's believed that the glycerol has equilibrated into the cell, The unit is centrifuged to remove the excess glycerol, and then it's frozen. Expiration, if it's frozen, it's 10 years. After deglycerolizing, because again, you've broken the seal, it's good for 24 hours. And I want to tell you that there are some blood types that are so very, very rare, and you haven't gotten into antigens yet. But for example, Solano. Solano is an antigen found on 99.9% of the population. So finding a donor who is negative for that antigen is virtually impossible. So what they do is when they identify a donor who has this unique, who does not have this unique antigen, then if the patient doesn't need the blood, then they will store it. And after 10 years, I would be very hesitant to even throw that out, knowing how difficult it is to find it. But that's between the medical director and the blood transfusion service as to whether there's a reason for keeping this unit beyond expiration. Because you deglycerylize it, so you're not going to recover as many red cells, but maybe 50% could save the life of this patient. Storage temperature, there's two types of glycerol solutions that may be used. High glycerol is nice because it has a minus 65 degrees centigrade storage temperature, so that's a laboratory freezer. Low glycerol must be stored at minus 120, which is liquid nitrogen. And not many hospital labs have a liquid nitrogen freezer in their facility. But the blood center, the donor centers, will most likely have these and store the units. So how do you prepare frozen red cells for transfusion? You have to use a process called deglycerylation. So the units are thawed at 37 degrees. The thawed red cells will have a high concentration of glycerol, which is not good for the patient. So what they need to do is remove as much of the glycerol from the cells as possible. So what they do is they add a solution of glycerol of lesser concentration of the original glycerol that was added. This causes the glycerol to come out of the red cells slowly to prevent hemolysis of the red cells. So if we used a 50% solution of glycerol, the glycerol in the cells would leave so rapidly that the red cells would pop. After a period of equilibration, the unit is spun, the solution is removed, and a second solution with a lower glycerol concentration is added. And this process is repeated until all the glycerol is removed. More steps are required for high glycerol stored units because they have a higher concentration of glycerol in the cell. After deglycerization, the unit is then washed. The last red cell component I'm going to talk about is rejuvenated red blood cells. This is done, rejuvenating the cells is done by adding a special solution to expired red cells up to 3 days after expiration to restore the 2,3-DPG and ATP levels to pre-storage values. The rejuvenated red cells regain normal characteristics of oxygen transport and delivery and improve post-transfusion survival. The expiration is 24 hours, but if you freeze it, it gets an additional 10 years. So why would we want to rejuvenate a unit of red cells? Well, those rare donors who lack a number of antigens, are the ideal candidates to freeze. Please write down your questions and bring them to class with you. This concludes part 1 of blood components.